70. Do I have an 80? No. It is about 70. 60, pretty close. So every contraction of the heart, 70 cc's of blood is moved. So let's put it up here on the screen. So we have 70 cc's coming in, right atrium, down to the right ventricle. We have an inferior wall MI. We're going to complicate this by making the right ventricle infarct also. You all know that the right ventricle is not a big pumping chamber. It is a very thin-walled structure that only needs to exert enough force against the blood to push it a short distance to the lungs. So when the right ventricle infarcts, guess what? It doesn't work very well. It contracts like mush. So that 70 that came in, when the right ventricle, now being impaired, contracts, guess what? Only half the volume comes out. So what was supposed to be 70 is now 35. Just by knowing that little piece, what is the major complaint of an RVI patient? Difficulty breathing. Why? There's no volume for gas exchange. They will be short of breath. And when you listen to their lung fields, will they be wet or dry? Why are they dry? There's no blood going there. The volume's cut in half. So these aren't patients that fill up with fluid. You listen to them, they're going to be clear. Now that 35 circulates around the lungs, comes back to the left side of the heart, down to the left ventricle. Left ventricle contracts, only 35 comes out. What's the next thing we look for in an RVI patient? Low blood pressure. Because only half the volume is being sent out to the system. Yes?
Would you say peripheral edema as well?
Be a little bit more specific.
What's
When you say peripheral edema, where would I look for that?
legs?
Not so much the legs. Neck veins, yes. So she brought me to my next point. 70 went in, only 35 came out. It begs the question, where's the other 35? It starts to regurge back up the right side. And in most patients, you're going to see it in their neck veins first. So this patient, you'll have them in a semi-sitting position. They'll have neck vein extension or distension. Why? Because there's a backup of fluid. So that's the triad of symptoms that we look for in an RVI patient. Here they are. Difficulty breathing, low blood pressure, and JVD. Yes?
So, with the regular 12 lead on 12, it's the inferior on MI, and we'll get the B4R. Why does that change B4, 5, and 6? As opposed to with a picture of a heart?
So if you think about 4, 5, and 6 are looking at the joining areas of tissue, you're going to get changes probably in all 3 of them. I'm telling you, you don't have to put all 3 patches on. B4 will give you the most information. Just isolate it to one patch, and if you see an indicative pattern there, you should have a concern with that patient. Okay?
So because they're all kind of the same
Yep.
area, that's kind of the source.
Right. So let's talk about low blood pressure for a moment. I'm sure you guys have heard these terms before, relative or absolute. Absolute hypotension is a no-brainer. Their blood pressure is low. It's in the 60s and 70s. What do I mean by relative? What's relative hypotension?
Less than what the patient's used to, less than their normal.
So good. It relates to what's the patient's normal blood pressure value. So that's the challenge for you as a healthcare provider. Do you always know what your normal patient's blood pressure is? You do not. So we make guesses. So when you have a patient with a textbook value of 120 over 80, is that normal or not? It depends. Depends on the patient. So Just don't go by, hey, it's below a value I see in a textbook. How does that relate to the way your patient's presenting? How does that factor in? So when it comes to treatment of an RVI patient, here's your concern. How many of you remember what Frank Starling's law tells us? That was quick.
It's the rubber band theory.
Okay, so define the rubber band theory.
The more blood that goes in to fill the container, the more it contracts.
Okay, good. So rubber band, as we pull the rubber band and stretch it, we're going to get much better snap out of it when we let go of it. Same thing with the heart. Right ventricle specifically, I told you when it infarcts, it doesn't contract very well. What if we were to fill it up with more fluid, stretch the fibers, we can get the ventricle to contract much more efficiently, and it's going to help eject that blood out so it doesn't become stagnant. That's our approach to care. They are preload dependent. So given that, and knowing that an RVI patient is preload dependent, this is what you have to be cautious with. Think about the medications that you give for ACS care. Aspirin, nitro, morphine. Guess what every one of those does? Depresses preload. So I'm not telling you that you can't use them, you just have to use them with caution.
What is aspirin?
Aspirin, believe it or not, as an antiplatelet, also has blood pressure effects. It causes low blood pressure. Not to the degree that you're going to see with nitro and morphine, but it does have that side effect as well. Most people don't understand that. It does.
You consider giving aspirin but not nitro or
I might initially, I might give them aspirin, but I might hold off on the other stuff until I feel comfortable with the volume status of that patient's body. So with these patients, nitro by drip works extremely well, somewhat prohibited in the field setting. But the other thing I'm sharing with you is one of the ways we change our approach to care is we give fluid. It's not uncommon for some RVI patients to get 2,000 to 3,000 cc's of fluid in the first hour of care. Now, I know that seems kind of counterintuitive. I'm going to dump all this fluid on an infarcting heart? The answer is yes, because you're going to get better performance out of the right ventricle. So with these patients, we think about large bore IVs, and even with a patient with a blood pressure of 120/80, guess what? They're getting a 500 fluid bolus before I give them any medication whatsoever, because they're going to need it. And if you've ever seen a RVI patient's blood pressure bottom out, you will never forget it, because you're going to be working against the 8 ball. You will take a 120/80, drop them down into 60 systolic, and you're going to have a hard time getting them back up. So don't contribute to the demise of your patient. Pay attention to this, it's important. Again, large lines, we talked about that, multiple lines. So take a look at the EKG on page 17. And tell me your thoughts there. Would you agree with the algorithm up here that this is an inferior infarct?
Yes.
Okay, everybody see 2, 3 in AVF? Strong reciprocation and 1 in AVL, yes? So you see up at the top of the slide, I've got a question mark behind RVI. Is it? How would we know?
Before.
We'd have to do a right-sided chest lead, correct? But what if there was information on the standard 12 lead that would tell me this is an RVI even before placing those leads? I'm going to tell you how to do this. And guess what I have to go back to? Your mean cardiac vector. I know there was a reason why I gave this to you early on. So we know that electricity flows down and to the left. Inferior wall injury complicated by RVI makes that vector change. Because of the infarct on the right side, there's a change in electrical flow. Watch the arrow. It swings this way. So if you look at our 30-degree offsets of views, this arrow is more in line with lead 2. As it shifts towards lead 3. How does that show up on your EKG? Take a look at lead 2 versus lead 3. What do you notice is different about the two? There's more elevation in lead 3 than there is in lead 2. Everybody see that? Also with that shift of the arrow moves proximally away from V2 towards V1. Now I look at these two leads. V1 and V2 should be mirror images of one another. They are not. One's elevated, one's depressed. That's because as the vector moves towards the positive electrode, it makes it a positive change. So there is evidence on this underlying standard EKG that this is an RVI even before I put the pads or patches on. Now, I know this is extra information. If it kind of blew over your head, I certainly understand that hearing it for the first time. But there's great information here. Again, going back and reviewing it, it helps. So what am I going to do? I'm also going to put on the right-sided chest lead and I'm just going to check. So here's that same patient. Here's my inferior wall MI. Right-sided chest lead was changed. Guess what? I was correct. There's an infarct going on the right side. So there's information there. It's how we utilize it and how it benefits us. Questions about that? How about some other RVI stuff here real quick? Going back to the proximal occlusion again on the right side. If my blockage is right here, everything distal to this is going to be compromised of blood and oxygen supply. Right at this area right here, where it takes a 90-degree turn down, that is called the crux of the heart. There is a very important conduction structure that sits right there. Who knows what it is? The AV node. The AV node gets its blood supply predominantly from the right coronary vessel. So think about this. Blockage is here. I've now got compromised blood flow to the AV node. AV node, if it doesn't get its blood and oxygen supply, AV node may not work very well. So what might happen to my patient? Bradycardia and heart blocks. So that's another thing that helps me diagnose an RVI patient. Look at their rate. Look at their rhythm. Put all the pieces together. And typically, when you've got blocks that occur due to a proximal occlusion, it's not because of a blocked vessel, it's because of increased parasympathetic tone. These are blocks that atropine will work on, because atropine is that parasympathetic blocker. Briefly, I want to mention posterior infarct. a patient that infarcts the back side of their heart. As you know, we don't put patches on our patient's back. So how do we diagnose that? We actually use reciprocal change. And we take the leads that are directly opposite, V1 through V3, which sit right on the anterior chest. So these leads right here. And we use reciprocal change. And typically what we're looking for is a presentation that looks like this, the carousel pony. So in red here, you have a very tall R wave that transitions in your early precordial leads. Here's the flat part of the saddle and the hump on the back of the saddle. Normally you would not see tall R waves in V2 and V3. Usually they're pretty short. So there's a way to diagnose a posterior wall MI from the front. Now, advanced stuff, but if you understand what it is you're looking for, and let's face it, if you really wanted to know, you could put patches on your patient's back if you wanted to. There are 15 and 18 lead EKGs. Instead of stopping at V6, keep going with V7, V8, and V9. And then, with patches directly on your patient's back, evaluate for indicative change. And then you can diagnose it straight up. I know some protocols are built for the additional patches. It's not hard to figure out. And as far as placement, V7 is in the posterior axillary line, V8 is right at the tip of the scapula, and then V9 is right along the backbone to the left side. Straight line across. And then last in this module, and we'll give you guys a break, it's the left coronary dominance patient. You've heard me say a couple times, you probably didn't realize it, where I talked about the RCA feed in 90% of the population. Where there's a 10% oddity out there, where their right coronary artery does not feed the inferior wall. The inferior wall is actually fed by the left circumflex. And a common infarct you'll see is inferolateral. So take a look at the EKG on page 20. Does everybody see the inferior wall MI here? You also see lateral elevation. So here's an inferolateral injury. Now, based upon what you guys know about coronary artery feeds, why doesn't that combination make sense? Inferior wall is fed by the right coronary vessel. Lateral wall is fed by the left circumflex. Could you have two blockages going on at the same time? Yes, it's possible, not likely though. What's more likely is one vessel is blocked and that one vessel is feeding both areas. So this is a left circumflex dominant patient. Again, if you do not know that, you still have information here. There's an infarct here. Would you still do a right-sided chest lead on this patient? Yes, I would. Most likely it's going to be negligible. A lot of information. A lot of review that has to go along with it. Questions? All right, why don't you guys go ahead and take a break, and then we'll tackle the last section.